Welcome. Good morning. My name is Merel Hilgersom. I'm from the Profundum Institution in the Netherlands. Besides working for the institution, I also work for the Profundum Academy. This is a teaching facility where we have several courses, all pelvic floor related. Besides working for Profundum, I also work for Novacare as a MAPLe trainer, and I work for the NTA as an ultrasound teacher in the pelvic floor region. As you can probably hear, I'm a bit sick today, so I have a bit of a cold voice. So if you don't understand me or you cannot hear me properly, please just say. What are we going to talk about? We're going to talk about the anatomy of the prostate, the robot-assisted radical prostatectomy, the nerve-sparing operation, the benefits of this operation, the operation itself, the possible consequences, what can you do pre-operatively, what can you do post-operatively, what's in science about robot-assisted radical prostatectomy and electrical stimulation, the MAPLe for diagnosis and treatment, and then we're going to discuss a case, and then it's the end of this presentation. So first we're going to start with the anatomy. I'm going to start a movie, and it's very clear, and I hope you will like it. And if you have questions during the movie, please just ask. So here you see the intestines of the male. The bladder and urinary system. Then we look sideways into the pelvic region, and there you can see the prostate gland, and it lies on the bottom of the bladder. Here you can see the prostate, the bladder, the rectum, and then, of course, the bladder at the urethra. And then you have the sphincter muscles that control urinary flow. Here you can see them. And of course, they can contract and relax, so you have continence, or of course, incontinence. The neurovascular bundle, which controls the sphincter and the erection, and of course, the neurovascular bundle. And as you can see, it's quite a complex surrounding with a lot of nerve system and blood vessels. The dorsal venous plexus. And then we can see a tumor develop in the tissue of the prostate. And as you can see, here's the tumor. And then, of course, we're going to talk today about the removal of this tumor. And with the rare procedure. So we're going to talk about the robot-assist radical prostatectomy, or the RARP. It's a minimal invasive surgery. It's designed to treat local prostate cancer, and it will remove the entire prostate gland. It has several benefits, such as enhanced precision and faster recovery times. The surgeon removes the gland along with the seminal vessels, and these will transport the sperm from the testicles to the urethra. Depending on the cancer risk, the surgeon may also conduct a pelvic lymph node dissection and remove nearby lymph nodes, reducing the cancer and the prostate. And there are less risks, so less chance of urinary incontinence and erectile dysfunction. It's a nerve-sparing operation. The aim is to preserve the nerve responsible for erection, which run along both sides of the prostate. During the nerve-sparing procedure, the surgeon carefully peels away the tissue layer on both sides of the prostate, like peeling the layers of an onion, in order to leave the nerve bundles intact while removing the prostate gland. Men who undergo nerve-sparing surgery have better chance of regaining erectile dysfunction and less chance of incontinence. I'm so sorry. The benefits of this operation: there's less pain, less blood loss, a shorter hospital stay, 1 to 2 days, faster recovery to normal activities within 1 to 2 weeks, faster return to weeks with 2 to 6 weeks depending on occupation. So for heavy lifting or so, you need 6 weeks. And better control of continence, erectile dysfunctions, and better cancer control. So here we're going to look at the procedure. It's not a real operation, so you won't see any blood.
You have been diagnosed with prostate cancer. Your doctor has recommended you to undergo a robot-assisted radical prostatectomy, or simply RARP. A radical prostatectomy is a surgical procedure where all of your prostate is removed. This animation shows how the procedure is done. RARP is carried out under general anesthesia. During a general anesthetic, medications are used to send you to sleep, so you are unaware of the surgery. When you are fully sedated, small cuts are made in your belly. Surgical tools and a camera are inserted through these cuts. The surgical tools are attached to the arms of a robot. These arms are controlled by the surgeon with a console, which is placed next to the operating table.
So what are the possible consequences? Well, it was already set into the movie, but involuntary urinary loss. You can also get an alternate orgasm. The length of the penis can be shortened, and they can have erectile dysfunction, and they will have a dry orgasm because the semen isn't going to the urethra anymore. What can you do preoperatively? Of course, you can train pelvic floor awareness. You can do this by palpation or exercises. Really important to inform and advise your patient about the operation, about the pelvic floor, about their liquids, about their miction frequency, miction advice. And of course, you want to teach pelvic floor function. And it's especially good to do this with EMG. And especially with the MAPLe, because with the MAPLe, the patient can see its own pelvic floor. And we know that biofeedback will improve and enhance results, so that will have better function preoperatively and therefore better outcomes after surgery. What can we do after surgery? Of course, we can train pelvic floor awareness again, give them information and advice, give them toilet advice, teach them pelvic floor function. Again, EMG would be quite helpful in this scenario. Teach them about intra-abdominal pressure regulation. This is also good to do this with ultrasound. And of course, training pelvic floor function, and of course, use the biofeedback and electrical stimulation, especially with the xMAPLe. This is really handful because you can treat your patient and see which muscle needs to be targeted. What's there in science about the treatment after the robot-assisted radical prostatectomy? So this is a systematic review out 2022, and there it says that electrical stimulation is beneficial for the treatment of urinary incontinence after the post-prostatectomy. Here we have another one, and again it says that biofeedback and electrical stimulation are very effective, especially in the first 3 months after surgery. So this presentation will be on the YouTube. So if you want to look closer to the articles, you can, and of course you can find them on PubMed. These are free articles, so you can read them all together, and maybe Anno can add them to the Novacare website as well. Here's the last one, again with biofeedback guided for pelvic floor muscle training and electrical stimulation after the radical prostatectomy. And it's quite beneficial and effective, especially in the first 3 months. But it also said that all pelvic floor treatments are beneficial. But yeah, it's good to know. So then we're going to talk about a case with a male who had prostatectomy. And of course, we're going to look at the complete EMG movie of this patient. And it's really important to look at these things. So what do you see in the linear graph? What do you see in the grid, and where? What's the relationship between the resting measurement, the maximum voluntary contraction, and the endurance contraction? How do you link what you see to the symptoms? And how do you link them to the dysfunction and, of course, the complaints of your patients? And what do you want to improve? So we're going to look at the case of Mr. Ivo Moleman. He was born on 2 January 1960. He's a janitor at a university. He's married and has 2 children, and he is happily married. He experiences stress due to his work, but also due to incontinence and impotence he got after surgery. It started with an increase in urination. He had 15 mictions a day. And after urination, he suffered from dripping. And when he was stressed or the weather was cold, the flow could be completely blocked and he couldn't pee at all. He experienced pain and a burning sensation after urination, and then he went to his doctor. And the GP took blood, and the results were elevated prostate-significant antigen. So the PSA values were up, and they sent him to the urologist. The urologist did an MRI and a biopsy, and the conclusion was prostate cancer. And he got the RARP in June 2023. After the operation, Mr. Moleman feels really angry and sad. The doctors had not properly informed him about the complaints that he could get after the RARP. He was not advised to get pelvic floor therapy. He didn't get it pre-operative, but not post-operative as well. And he got urinary incontinence and impotence. So he's really sad about this, and he didn't know this could happen. The date of the intake he got to my facility was 18 June 2024. He got severe incontinence, PRAVAPS 14. This is a Dutch questionnaire and means severe incontinence. I get a question.
Just a remark from the AI bot.
Oh, okay.
Sorry.
His micturition is 10 times a day, 2 times a night. He still has dripping after micturition. He wears a diaper. He uses 2 during the day and 1 during the night. He feels stressed, sad, and it's like he lost his masculinity. Defecation once a day. It's quite normal stool. He scores it with a Bristol stool score 2 to 3. He has a hemorrhoid and sometimes clear blood after stool. And he has no fecal incontinence. He sometimes has incontinence of flatus since the surgery. Sexology, he experienced impotence and is very sad about this. He is ashamed of his powerlessness. Before the operation, he had no sexual disorders. He hoped that he will get his erection back. Orthopedic, sometimes he has lower back pain, but he hasn't had it at this point. And his health regrets, he would like to get rid of the incontinence and impotence, and he has no idea what the treatment could look like. So here are some results of the investigation I did, the inspection. He had no skin particularities. He had a small hemorrhoid at the level of the sphincter. When I asked him to contract, he mainly used his glute muscles. He didn't have a calf reflex, and he had a paradoxal push. I didn't include the results of the internal investigation because I want you to have a clear mind before we start the EMG. But I did do the ultrasound investigation as well. He had diastasis recti, and his transversus muscle wasn't functioning properly, and his diaphragm is stuck. So he has a high breathing pattern, and the multivity muscle wasn't contracting at all as well. So we're going to look at the initial measurement, and I would like you to all look at the measurement, and we're going to discuss the measurement afterwards or during, whatever you like. I will stop the movie after each part of the measurement, and then we're going to talk about it. So first we're going to start with the resting measurement. This is a measurement that will take a duration of 1 minute. During this minute, the patient cannot talk, cannot move, and just needs to lay down to, in my case, his side. He was on his left side. I'm not talking as well. I'm looking at my iPad and to the patient. And this was what I was seeing. A normal anal resting measurement should be above 0 and below 4. And in this case, all 24 of the electrodes are active. So this is the first minute. I will stop the movie so we can discuss what we just have seen. So who would like to join me in discussing the resting measurement? What did we see? Was there any dysfunction, or was it just a perfect resting measurement? Who would like to give it a try? Nobody? Well, then I will tell you what we have been seeing. I will reverse the moving a bit. As you can look to the grid, you see a lot of dark grays and even blacks. So during rest, you don't want to see dark grays and blacks because it means overactivity. If you look to the average, you will see an average of 11.0 microvolts. And as I just told you before, it should be above 0, below 4. So this is almost 3 times higher than it should be during rest, but all 24 are active. So this is not a specific resting value. If we look into the muscles on the left side, you can see that partially ileococcygeus, pubococcygeus, puborectalis, and the external sphincter are overactive. On the right side, we can see mainly puborectalis overactive, and on the dorsal side, puborectalis partially, and the external sphincter. Do we all agree, or does anybody see anything else? I see some head shaking, so I think everybody agrees. Then we go into the next measurement. What could this mean for this patient? Can the overactivity explain some of his complaints before we go further? Karen, I see you nodding your head. Can you tell me what's the relationship?
If you're already contracted in a resting tone, you can't be more active in when the intra-abdominal pressure is rising. And his peeing problems can also be, yeah, what do we say? Ontstaan, help me.
Occur.
Occur when your resting tone is so high.
Yeah. So, of course, when you have overactivity, as Karen explained, you get problems with contracting, with intra-abdominal pressure, which can affect the urinary incontinence, but also it will affect the blood flow to the penis. So therefore, you can get erectile dysfunction. So this can explain both of his symptoms. So then, yeah, let's check. Then we go into the next measurement. I will do a specific measurement. So as you can see, oh, I'm pressing the wrong button, but I will go back. I will deactivate some of the muscles so I can see the specific activity of the puborectalis muscle. So only the green ones are active on the left and on the right, which relate to puborectalis. And as you can see, the average is now even up between 25 and 30 microvolts. This is extremely high. Especially when you keep in mind that it should be below 4 during rest. So yeah, there's a big problem in this case. And as we ran through the case, you can also see he has a lot of psychological complaints. So he has a lot of stress, anxiety, he's a bit mad. So that together with, of course, the physical complaints can explain some of his symptoms as well. So now we're gonna check out ring number 4. And the activity is better, but it's still almost 3 times as high as it should be. If you want to do a specific measurement, you need to at least film for 12 seconds. Otherwise, you cannot save your specific measurement. Then we're gonna use the mode against a healthy person. And then, as you can see, the red ones are more active than a healthy person. White are the same and blue are less active. And I will pause it for a second. This is also the reason why I don't use this function that much. Because if we looked at the absolute measurement, I told you sphincter muscle was overactive. And if we look against the healthy person, it should be less active than a healthy person. So the group of subjects for the healthy person study is really small. And we don't have the 0 waiting point line. So I find this really hard to explain because when I look to my patient closely, I see overactivity. And when I compare him to somebody who's healthy, it should be, underactive even. While we know everything above 0, below 4 is overactive. So it's just to show you, but I hardly use this measurement. The red, of course, is really clear, but then with a resting tone of almost 30, I think that's not healthy at all. Then we're going to look at the MVC measurement, so the maximum voluntary contraction. This is the contraction within 3 seconds. So it's not a fast contraction, contract, less loose, but it is a contraction within. So I will run to the movie. Contract, let loose. Contract, let loose. So as you can see, the patient is already letting loose way before I'm instructing him to. And what we're looking at is, of course, the onset timing, the offset timing. Can he hold for the 3 seconds that I'm asking? And what do we see in the grid? And in the grid, we would like to see everything turn to black during the contraction. And during the resting time, we would like to see everything light gray again. So Mr. Moleman isn't giving me quite what I would like him to do. And it does explain his symptoms. But I would like to discuss it with you all. What did we see? Did we see a good onset time? The onset was okay. Did the patient hold for 3 seconds? Not even closed, right? It completely let go right away. So coordination and duration weren't good. The offset timing, how did you think the offset was going? It wasn't good. There's a delay at the end, and you see some peaks during relaxation. And if we look to the grid during the contraction, we're now in the contraction. I put the movie to pause in a contraction. As you can see, the same muscles that give the overactivity during rest are the only ones who properly regain activity during contraction. So this isn't a proper MVC measurement. There's poor coordination, there's poor activation, poor relaxation, and it will give you an explanation for the urinary incontinence, especially if you look into the anterior segment, because in the anterior segment, there's the urethral external sphincter. And as you can see, there's some improvement of activity, but it isn't turning black at all. So the urethral sphincter isn't contracting properly. Levator ani isn't completely active, and there's poor coordination. And again, for erectile dysfunction, you need to have good MVC as well. So again, we have some good explanations for the problem Mr. Moleman is experiencing. We're going to go into the next measurement. So the last measurement we're going to look at is the endurance. This is a contraction. Oh, I need to activate it. A contraction within 30 seconds. It's a submaximal contraction. The patient needs to breathe during the contraction. No compensation of other muscles, of course. And during the pause, he should be completely relaxed. And again, we look at the linear graph. What do we see in the onset timing? What do we see in the offset timing? What do we see in the holding time? And what is happening into the grid? And of course, can we explain the symptoms by looking at what we're seeing? And I think really important to keep your eyes during rest as well, because sometimes it can give you quite important information, such as less activity in the grid, which could explain tiring out muscles during activity. And we kind of see it here. And of course, what's happening after the offset? Is there relaxation, or is there, again, hyperactivity? And keep in mind, with EMG, we don't talk about strength, we talk about activity. So it's no improvement of strength, it's improvement or increasement of activity. The second contraction, not a really good onset, as we can all see. And then again, I'm asking him to hold, but it isn't a quite stable hold. He's really trying his best. And what you cannot see in this movie is that he's stops to breathe during the contraction, and he's also using his glute muscles. So I don't correct him during my diagnostics, but I, of course, will write down the compensations. And when I'm starting to treat, I, of course, instruct him to do this in other ways. And what we see during rest, so there's less overactivity during rest, is also quite beneficial for electrical stimulation. Because if you use the preset overactivity and then the interval and use a really long holding time, you will tire out the muscle as well. And therefore you can use it to decrease muscle activity, and it would be quite a good option for this patient. Of course, you can use other settings as well, which we're going to discuss later on. The last contraction. And as you can see, Mr. Moleman is getting tired. And then the end of the last contraction. Almost no difference in contraction and relaxation anymore. Then we can look at the overview. Here you can switch between all the resting measurements. You can switch between contractions. And if we look to all the grids, you can see that the muscles that are active during contraction are the same that are overactive during rest. And then, of course, you can also look at the graph measurements and print out your report. I find the report really helpful, especially it saves me writing time into my documents in the computer, because I can just attach this to my patient file and I can send it to the specialist if I want to. And the note section I really like as well, because there I can write down the compensations of the patient. And then when I look back at it, when I do my remeasurement, I don't have to look into the patient file. I can just find it into my iPad. And then, of course, you can save it. So the conclusion of the measurement, I think we all discussed it already quite a bit, but would somebody like to try the conclusion? This is always the fun part where everybody is shy to say something, but I will help you out. So we have an overactivity of puborectalis on both sides, and we have an overactivity of the external sphincter on the left, the posterior, and the right side. Ring number 5 is overactive as all in 3 segments, but it's not connected to specific muscle tissue. During MVC, we have an okay onset. It could be better, but it's within 1 second, so we could say it's okay. We have poor coordination and poor holding function. The offset is delayed, and if we look into the active muscles, only the muscles that are overactive during rest are active during the MVC as well. And then if we look to the endurance, no, there is not really a good onset time. The holding is quite variated. Offset, there's almost no difference between the holding activity and the resting activity. You see a small dip after relaxation, but afterwards it gets up high in the overactivity again. But what you do see during endurance is that the overactivity gets less. So you tire out the muscle by holding the muscle function, and this gives you good information for your treatment. I'm sorry, I'm going to take a sip again. So the overall conclusion, we have overactivity of the puborectalis, ring number 5, and the external sphincter. And we have poor MVC and poor endurance of all the other muscles, especially the anterior segment, the anterior side of the pelvic floor, isn't functioning at all during fast or slow twitch, which are both really important for urinary incontinence and impotence, as well as the dorsal side, so the posterior side of the pelvic floor. Levator ani isn't doing it at all. And those we need as well. So what are we going to do for treatment? Of course, we're going to do a lot of other things besides the MAPLe. We're going to give micturition advice. We're going to give lifestyle advice. Of course, I'm going to use the MAPLe for electrical stimulation and biofeedback. But I'm also giving pelvic floor awareness, relaxation and function exercise for fast and slow twitch. Keep in mind, the MAPLe isn't magic, so your patient always has to do home exercising as well. And if they don't do the home exercising, the treatment will be less effective. And of course, some motor control training for the diastasis recti and to improve intra-abdominal function. This is what I did with electrical stimulation, and I did some biofeedback as well. So I worked on deactivation of the overactive muscles, and I started working on fast and slow twitch with electrical stimulation. For the deactivation, I used the thalamus release. It's a really fast and easy way to decrease function of activity, sorry, and it kind of feels good for the patient. It's a really kind, gentle electrical stimulation, and it feels a bit like a heartbeat. And then for the fast and slow twitch, I used an interval training. I switched between rings and sides, and I variated in holding times for the slow twitch training. For fast twitch, you need to be within 1 to 3 seconds, and for slow twitch, you can be from 3 up to whatever you like. And then, of course, with biofeedback, I worked on the coordination of this patient. I saw the patient for 6 sessions, and this was my final measurement after 6 sessions. And I think we can all agree that these are quite impressive and quite some improvements. So if we look into the overview, you can see good resting tone. If we look to the MVC, the complete dorsal side is active again, and in the anterior side, it isn't as active as the other parts, but that's where the prostate is as well. So there's probably still some nerve irritation or maybe even nerve damage due to the operation, but it is function enough to regain his complaint, to get rid of his complaint. And if we look to the endorsement, almost everything is active. If we look into the graph overviews, you can now see that coordination is improved, on and offset is improved, the height of the MVC, from the EMG contraction is much higher, and the resting measurement is much more stable. So this patient doesn't have any urinary incontinence anymore, and he completely regained his sexual function. So this is a really, really happy male. I think we can say that there was no severe nerve damage by operation, because in 6 times he completely regained function, even though the operation was quite some time ago. So if we look back into the articles I put into the presentation, those were from the first 3 months after operation. This is quite some time after operation, and still such an improvement. I think it would be fun to do some investigation with the MAPLe after prostatectomy. Of course, science should be higher with MAPLe. There are just limited articles available at this point, but research takes time and it costs a lot, of course. So maybe in the future, but I think it would be really interesting. Well, this is the end of my presentation. I hope you all enjoyed, and if you have questions, please ask. I think everybody is okay. Oh, Greta.
Ja, moet je altijd een ring overslaan of mogen we 2 ringen opeenvolgend nemen voor te stimuleren? Of,
She's asking if you should always leave 1 ring in between with stimulation, or if you can use 2 rings besides each other. Sorry, I need to take a sip again. Well, you can do both. It's more effective in most cases when you leave a ring in between, because then the current runs over the muscle. But if there is lack of sensitivity or lack of nerve function, you can put 2 rings beside each other as well. But in most cases, it feels more irritatable to the patient. So I would recommend, if possible, leave 1 ring in between.
Dank je.
You're welcome. Are there any more questions? I think everybody is okay. So I'm really sorry about my coughing and protesting voice during the presentation. I hope you still could understand me okay. I think this presentation will go into the YouTube channel of Novacare.
Yeah, correct.
I would like to thank you all for attending today and have a really nice day or evening, depending on your location. And thank you all.
Thank you.
Bye-bye.